Pneumothorax. So pneumothorax is basically air into your pleural cavity, and it's seen as small or large. There is tension pneumothorax and spontaneous pneumothorax. So if it's a small pneumothorax, that means it's typically involving like less than 15% of your lung. It's less than 2 centimeters. If it's more than 15% of your lung, it's a larger pneumothorax. So smaller pneumothorax just requires giving oxygen and observing. So in a tension pneumothorax typically develops because of trauma. Spontaneous pneumothorax is typically seen in Marfan syndrome and in COPD patients when those blebs just spontaneously burst. So the management of it depends on whether it's just a pneumothorax that is stable versus that has something that's progressed to a tension pneumothorax. So in pneumothorax versus can be large or small, and if it progresses to a tension pneumothorax, that's when you have elevated JVD, drop in blood pressure. On the chest x-ray, you see the mediastinal deviation. So that's when a pneumothorax has progressed. So now the management becomes, in a very acute setting, diagnosis is typically done with a bedside ultrasound. But if the patient is a bit more stable, then you can do a upright chest x-ray. Then the first step would be a needle thoracentesis. So needle thoracentesis can be done either mid-clavicular, second or third intercostal space, or mid-axillary in the fifth intercostal space. So that's when you hear that swoosh of air. But that's not enough. The next step is to do a thoracostomy and then put a chest tube in. And every single time you put a chest tube in, you need to hook it up to an underwater seal and get a chest x-ray just to make sure it's in the proper placement. So that's about it.